4 minutes into a college basketball game that pitted the University of Florida Gators against Florida State University, Keontae Johnson, the Gators' leading scorer and rebounder, leaps into the air and puts down a massive slam dunk. The crowd roared and a timeout was called. But a moment later, as Johnson walked back onto the court, his steps slow and he falls face first to the hardwood floor, his 6'5" frame dropping straight and motionless as if a tree was cut in a forest. Medical personnel hurried to his aid using a stretcher to take him off the floor. He was quickly taken to a nearby hospital for further evaluation. Some of his players cried after Johnson collapsed, and several of them knelt in prayer during the huddle afterward. Johnson, 21 years old, underwent an MRI at UF Health in Gainesville after being transferred there from Tallahassee Memorial, at which point a doctor reportedly diagnosed him with acute myocarditis. Welcome to the Healthy You podcast from NorthShore University Health System, where we explore trending topics in healthcare. I'm your host, Carolyn Starks.
And I'm Jon Hillenbrand.
Today on Healthy You, does COVID-19 pose hidden heart risk for young athletes? We'll talk to NorthShore cardiologist Dr. Jason Robin. What is myocarditis? Why is it connected to COVID? And what tests should our athletes get? Welcome to the podcast, Dr. Robin.
Thanks for having me.
Let's start with having you take a look at this bone-chilling video and tell us what you are seeing, if anything, medically.
Did you want to, have you seen the video that she's talking about?
I saw the video when it first came out that I know was taken off of YouTube for a while, but I have seen
it. Oh, really?
So
okay.
He hit slam dunk, goes into the timeout, then comes out of the timeout walking towards half court and collapses.
Right.
Keontae Johnson video. Here it is. Oh, geez, that's scary. I'm sure there's more you can see than we can see, but it's so sad.
Can you actually see the video online?
Yeah, I just sent it to you.
Okay.
Oh, my God.
So I do recall the day that this happened, and they did show prior to his collapse, him going up for a slam dunk, and looked healthy as could be. This is one of the top basketball players in the country, predicted to be a top 10 draft pick in the NBA. They call a timeout, and after the timeout, you can see him walking towards half court. After about 3 or 4 steps, you can see that his head goes down, and he is struggling to keep his leg strength. And as you said, he goes right down face first. Almost certainly what's occurring at this point, when you see his head start to go down, is he's having an arrhythmia of the heart. Most likely, this was ventricular tachycardia, which means that the bottom chamber of the heart was going probably somewhere between 160 and 250 beats per minute.
Wow. To give you an idea of what that's like, here's a heart rate of 75 beats per minute, which is you sitting in front of your computer. And here's a heart at 250 beats per minute.
When the bottom chamber of the heart goes that fast, it's not able to sustain much of a cardiac output. The blood pressure drops and the person collapses, and we call this syncope. The majority of the time when we see syncope, it's usually a benign process, such as when you have your blood drawn and you see your own blood, or maybe you see a mouse going across the room. Although in certain situations it can be much more ominous. And anytime we see somebody pass out in the setting of heavy exertion, it definitely brings up the concern that it could be cardiac in nature. And in this case here, there was no question that this was cardiac in nature based on how he had no time to prepare himself for the fall and how quickly he went down.
So part of me thinks you're saying this is fainting, but I'm also so it's not a quote-unquote heart attack.
This is not a heart attack. A heart attack is when one of the arteries that's supplying blood to the heart muscle abruptly closes and there's not enough blood flow going to the heart muscle. And that typically presents with chest pain or shortness of breath. Would be extraordinarily unusual in somebody who is young like this. This is syncope, which is synonymous with fainting. And when people do faint, again, 95% of the time, it's a benign cause. In this case here, it certainly was not a benign cause, and it was originating from a heart problem. When we think about the different causes of syncope, sometimes it could be, again, a vasovagal event, which is just a reflex that you might have after being scared or anxious. Sometimes there's certain things that we can do to make ourselves pass out, like if we're urinating or defecating, if we're pushing too hard, coughing can cause syncope. Those are benign causes. Being dehydrated can cause syncope. Here, though, we're talking about an arrhythmia of the heart that caused his blood pressure to drop quickly, and that's what caused him to pass out.
Okay.
It's pretty scary.
Very scary. But, all right, so I have a ton of questions. I'm here to ask the stupid questions. Everyone's embarrassed to ask,
There's
right?
no stupid questions.
Okay, thank you. There'll be some intelligent ones in there, too. So, in hindsight now, of course, this has been about more than a month since this happened. And we know that reportedly he had acute myocarditis, possibly due to having a COVID virus over the summer.
That's correct.
Okay. What is myocarditis? Let's just start there.
So myocarditis is inflammation of the heart. And specifically, it's inflammation of the heart muscle. The heart muscle we call the myocardium. Itis means inflammation, so myocarditis is inflammation of the heart muscle. And there are various reasons why one can get myocarditis. The most common reason is typically after some sort of infectious process, usually a viral process. So we've been seeing myocarditis for years and years and years. So someone who presents with a random upper respiratory tract infection, and then they present to the doctor a week or two afterwards, and they have some chest pain with breathing or some shortness of breath, we can make the diagnosis of myocarditis. There's people who have autoimmune diseases such as lupus and rheumatoid arthritis who can sometimes get myocarditis as well, where their body is actually attacking the heart muscle. There's certain medications that can precipitate myocarditis. So there's a vast array, but the most common reason is typically after an infectious process and usually after a viral process.
And this would go undetected by him if he... Presumably, if he was, it could go undetected. If he had no symptoms, nothing wrong, maybe just minor symptoms and he brushed it off, or?
It's unusual to have no symptoms at all and to have this be the initial manifestation of myocarditis, but it is possible. The vast majority of people who have myocarditis will have some symptoms of chest pain or shortness of breath, some lightheadedness, some dizziness, maybe some palpitations. But when, in a case where the myocarditis is significant and there's enough inflammation to really irritate the heart, you can get a presentation such as this where there is an arrhythmia of the heart that causes one to pass out.
Okay, so you mentioned inflammation of the heart muscle?
Correct.
Okay, so what does that look like? How inflamed, I guess? And does it increase the size of your heart or no?
So when you look at the heart of somebody who has myocarditis, often what we'll see is edema or fluid within the heart muscle that normally would not be there. So no different than if you were to take a hammer and hit your toe, the toe would actually become swollen and inflamed. It would change in colors, it would become warm, and then you would get inflammatory proteins that would go to that area of the toe and cause fluid to seep out, and that's why the toe gets big after you take a hammer and hit it. Don't do that at home.
Get the best advice.
Thanks for that. God, I'm so glad he told us.
Myocarditis is the same process where there's an inflammatory condition that can actually cause some edema to form within the heart. But the heart itself is typically normal in size during the acute myocarditis phase. People who have ongoing or chronic myocarditis lasting months and months after the initial hit can often develop the heart muscle to start dying. And then at that point there, the heart will start to dilate and get bigger.
So we know that he has since recovered and is out of the hospital. I know he was transferred from a Florida hospital to a more specialized hospital.
Correct. Well, we know that he did have an MRI, and the MRI, per the reports, was very suggestive of myocarditis. One of the tricky things with myocarditis is differentiating between acute versus chronic myocarditis.
Mm-hmm.
And it's sometimes even difficult to determine whether or not it's acute myocarditis or it's a healed myocarditis. In other words, somebody could have had inflammation of the heart months or even years earlier, and we do an MRI, and what we're seeing is scar tissue, but not active inflammation. And those nuances of differentiating between acute active myocarditis, chronic myocarditis, which may be a chronic inflammatory state, or an old healed myocarditis, those are very difficult to distinguish between the three. That being said, all three of those entities, the acute, the chronic, and the healed myocarditis, where there's just scar, that's healed myocarditis, all three of those can cause arrhythmias and can cause passing out.
So do you think his examinations after he had COVID, because I read that he would have to have a medical evaluation before returning, that his heart would have to have been rigorously checked before going back onto the court. Could they have missed something?
The diagnosis of myocarditis is definitely not an easy diagnosis to make. MRI is probably one of the more sensitive and specific tests that we can use, although MRIs are not easy to get. And we typically don't recommend doing MRIs unless our clinical suspicion for myocarditis is very high. He may have had an electrocardiogram, which is a way to assess the rhythm of the heart. That's just that piece of paper that takes 10 seconds to do in the doctor's office. He may have had an ultrasound of the heart, which takes a look and see how the heart is squeezing, and that's called an echocardiogram. And he may even had some blood tests as well. But none of these tests are perfect, and what makes it even more complicated is that the electrocardiograms and the echocardiograms in athletes, especially big young athletes, often tend to look, quote-unquote, abnormal. In other words, the heart of Keontae Johnson is going to look a lot different than the heart of a 45-year-old man who's 5'9", 150 pounds, who's going in for a insurance policy echocardiogram. The hearts of athletes can often be dilated. So if we look at athletes who are soccer players and cyclists and runners, these are athletes that increase their cardiac output significantly for many, many hours during the week. So your normal cardiac output is about 5 liters per minute. So what that means is that you take a liter of pop, well, fill that up with blood, take 5 of those liters, and every minute that's how much blood your heart is pumping through the circulation. Mm-hmm. Soccer players and cross-country runners, they, for prolonged periods of time while they're training, can increase their cardiac output to 20, 25 liters per minute. And when that happens, the heart can have some structural changes that are adaptive, and the heart can sometimes become more dilated. And some people may think, well, this is an abnormal heart, but it's really not abnormal. It's just physiologic based on the type of training that athlete does. There's other types of athletes who do more intense anaerobic training, such as power lifters, offensive linemen, wrestlers, where they increase their blood pressure significantly for prolonged periods of time very quickly. And those athletes tend to get thicker heart muscles. And so again, you have some athletes with thicker heart muscles, some athletes with more dilated hearts. So it's not easy to distinguish between an athlete's heart and something that can be pathologic.
Mm-hmm. And you really have to know, as the cardiologist, the full story of the patient and what they're doing. And
that's correct.
Yeah, my mom played volleyball for many years, and she had an extremely low resting heart rate, like 40 something. Yeah. And even now that she's less active because she's older now, she still goes in and has a very low heart rate.
And again, those are physiologic manifestations of being an athlete. My father-in-law was an Olympic swimmer, okay, and he lost to Spitz, but he was in the same class as Mark Spitz in 1972.
I wouldn't mind losing to Spitz.
when I looked at his echocardiogram when he was in his mid to late 60s, he had an aorta that was very, very dilated. So something that we see in people who have long-standing hypertension, often smokers. Sometimes we see it in people with congenital issues that cause their aorta to be dilated. And he, like many of the other athletes that I see who train for years and years, it was just a physiologic change, and that's why his aorta was a little bit more dilated. So intense training can cause changes to the heart, and it takes an experienced cardiologist, often a sports cardiologist, to differentiate between pathology and just normal physiology.
Is it possible that the myocarditis could have been tempered or subdued when the test was done and it comes back raging later on, or no?
Well, first of all, my experience with myocarditis is if we're doing echocardiograms, especially just basic echocardiograms, the echocardiogram can often be normal. So it's really a matter of getting many, many pieces of data together and also, be taking a very, very focused history to make sure that the patient is not having any symptoms. It is possible that everything could have been normal on his echocardiogram. What I am a big proponent of is in patients who I think may have myocarditis is doing a more sophisticated echocardiogram, which I don't know if he had or not, but it's called an echocardiogram with strain. And when we do the strain analysis, what it allows us to do is look at the heart muscle in tiny little segments to see if there's the smallest amount of pathology on a microscopic level. And there are some small studies that have shown that if you use this technique with echo, the findings are actually they correlate well with cardiac MRI. So if he didn't have an echo with strain, it's very possible that he may have had just a benign looking echocardiogram.
Is that like a stress test where someone's on a treadmill and you do an EKG or something like that?
So it's slightly different than a stress test. It's we're not stressing the patient per se. The strain is actually looking to see how well the heart on microscopic segments deforms. So if you're looking at the heart globally, everything looks perfect globally. But then we're looking at the heart on a microscopic level to see how well the heart is doing in different segments microscopically. So it's called a strain analysis. Stress tests are very, very good tests too if you're concerned about myocarditis, because often if someone has active inflammation of the heart, when we put them on a treadmill, what we'll see is arrhythmias on the electrocardiogram. So when we do a stress test, we're looking at an EKG, so we're looking at one's heart rhythm, and then we're also going to image the heart also. And often on the electrocardiogram, we can see arrhythmias of the heart in somebody who has myocarditis. In this case here, had Keontae been monitored with an EKG during his stress test, undoubtedly what we would have seen is before the game and probably during the first 2 minutes of the game, some extra heartbeats, and then clearly before he passed out, a run of a ventricular arrhythmia, likely ventricular tachycardia or ventricular fibrillation.
So this would not happen to him at resting?
Yes. And that's one of the reasons that when people have myocarditis, we restrict them from participating in heavy conditioning for at least 3, often 6 months, because the strain that one puts on the heart or the stress that one puts on the heart in the setting of active inflammation can irritate that heart muscle more so and cause these sorts of arrhythmias.
All right, I'm going to assume the role now of a parent. Let's get into I am a parent, but...
Apparently.
Good one. Let's talk about what parents are thinking. We have a lot of young athletes here, and I want you to help us put it into perspective in terms of the rarity of this for young athletes, what parents should do, what symptoms, and then what test we perform here at NorthShore. So let's talk about the incident rate for young athletes. And when we're talking young, how young could this be seen in, I guess? Start there.
The one thing that this pandemic has done is it's caused us to maybe be a little over-vigilant or hyper-vigilant in trying to assess for cardiac inflammation. And the reason for this is there was a study that was published in Germany right at the onset of the pandemic, and it took people, their average age was about 50, who had COVID. About a third of those patients were hospitalized. So it's a different group of patients than what we're seeing with young athletes. But they did MRIs on every one of these patients who had a COVID diagnosis. And about 50% had MRI evidence of myocarditis. So that got the whole world spinning, saying, wow, this is a different virus than what we've ever seen before. Even though we've known for years that just random upper respiratory tract infections can cause a myocarditis, 50% on MRI, that's a really, really high number. It caused a lot of concern, and for that reason, this was in the summer of 2020, college football put their foot on the brake. And for example, the Big Ten and the Pac-10, they both were talking about not having a college football season because they were so concerned that with the spread of the virus that we were going to see a large number of kids develop myocarditis, which is a scary diagnosis to be given. So for that reason, many of these conferences, what they did is they made a policy where if a kid had a positive diagnosis of COVID, they would get an MRI. So that's what was being done in the Big Ten, I believe in the Pac-10 as well. I'm not sure with the SEC and the ACC. And that data has been published. And what it showed is that about 15% of the kids who had a positive diagnosis of COVID had MRI abnormalities. So that caused even more concern. Are 15% of the kids who have COVID, are they developing myocarditis? The problem is that we don't know what the MRI is supposed to look like in an 18, 19, 20-year-old Division I athlete, okay? And it kind of goes back to how we think of EKGs. There's a lot of people who believe in doing a screening EKG on every kid who participates. It's not a bad idea, and we're going to catch some kids who may have some things where it's not safe to participate. However, it took a lot of time for us to realize that the EKG of a 18-year-old, 6'4", 275-pound offensive lineman is going to look a little different than the 45-year-old man who's going in for an insurance policy. So the MRIs just may be different in these athletes. They may have a little bit of inflammation, not necessarily from COVID, but they may have inflammation just because they work their butts off, and they can have some inflammation from just exercise and whatnot. We don't know. That being said, despite that number of 15%, 20% with abnormal MRIs, the incidence of clinically significant myocarditis in young people who have COVID, who are either asymptomatic or have very mild symptoms of COVID, is very, very, very low. And that data will be coming out within the next couple of months or so. And that's one of the reasons that the newest guidelines that were put forth by the American Heart Association say that if you are a young athlete who got COVID and is asymptomatic or had a little bit of a runny nose, a fever for a day, a little bit of a cough, loss of taste or smell, those sorts of symptoms without any sort of cardiopulmonary symptoms, do your quarantine, get healthy, sit out for 7 to 10 days or so, you can go back to participate because the incidence of clinically relevant myocarditis is so low. For people who have more than mild symptoms, so for people who are having persistent shortness of breath, they're having chest pain, they had fevers for many, many days, significant muscle aches, those are people where we think that there might be a higher incidence of clinically relevant myocarditis, and those kids are the ones who probably should have some sort of screening before they go back to participate.
You and I have talked about a patient, a NorthShore patient, Sarah.
Hi, my name is Sarah Barbosa.
Who's a freshman in college, three-sport athlete in high school, and was experiencing things that I thought, as a parent, that would be frightening to me.
I am 18 and live in Gurnee, Illinois, and I attend the University of Kentucky. I woke up early November. It was the first week of November, and I woke up with 101, 102 fever and this crazy pressure throughout my head and my neck. I could not break my fever for 3 or 4 days. I tried Tylenol, I tried cold and flu medicine, nothing would work, so I pretty much just stayed in bed. And then once my fever broke, every other symptom of COVID just kind of came along afterwards. I had the runny nose, I had a bit of the sore throat, I lost my taste and smell for the next week and a half.
And then you returned home weeks later for the holidays, right?
Yes. So I actually noticed the first time during COVID, I had drank like an energy drink just that I had sitting around in my dorm. And the next morning I woke up with crazy bad chest pains, even when I stood up, just super, super bad. So I tried to stay away from caffeine. And my first day out of quarantine, I walked to my car in the parking garage and was completely out of breath. And I was actually sweating, which was super unusual for me. I've always been super active. In high school, I played 3 sports and I would attend 6 to 8 hours of practice every single day and bounce between sports. So it was never something that I had ever thought would happen to me. And then when I came home, I was just unloading the car. I was out of breath. And then over the next few days, I was just kind of doing my laundry from being home. And I was just bringing a basket of laundry up the stairs. We only have like 8 stairs that I had to go up. And once I got to the top, once again, my face was red, my heart was racing, and I was super out of breath.
So that told you became a little bit more concerned?
Yeah, I definitely at that point, I think my mom and I were a lot more concerned because like I had never had any problems, no prior concerns with anything. And suddenly now I'm walking up the stairs and I'm out of breath and having this really bad chest pain, which had never happened before. So yeah, I definitely became a lot more concerned at that point and wanted to get in to see somebody just to make sure everything was okay.
Do you remember what cardiac test they did?
Yeah, so the first appointment I went in, they did an EKG and everything looked normal on that. And they were trying to schedule me in on the same day for an echocardiogram, but they couldn't. So I went back the following week and got an echocardiogram done.
And what were the results?
Everything looked good. He said I had a perfect little heart and there was no real concerns right now. And he said, obviously, if it doesn't get better within the next couple months, I have to go back and to keep exercise and everything else kind of at a minimum and just lay low and let the effects kind of ride themselves out.
So it could be your lungs then, not your heart, that are still damaged from the virus.
I mean, I guess I'm not even really sure. But with right now, there's no concerns for my heart. But even the other day, they told me, like I could work out in moderation here and there as long as I'm being careful. And so I've been going for walks. I was taking my dog for walks and then I was doing walks with ankle weights just to see if I was okay and I wasn't sore. I wasn't having any breathing problems. And the other day I was like, well, I'll finally try to go for a short run. And I got about 4 streets away and it felt like my lungs were all fuzzy and I was coughing and it was just not good. So definitely something I might have to get checked out if it doesn't get better once again.
So do you feel good, though, that you got your heart checked out? Because the heart's, like the brain, the center of our bodies that keep it going.
Of course. Yeah, definitely. I definitely feel a lot better after knowing. And the echocardiogram actually, like you can sit there and watch it as they do it and you can see your heart and all the different ventricles and everything and what they're looking at, which is super, super cool. Mm-hmm. And it definitely put me at ease, kind of knowing like, okay, well, there's nothing wrong as of now. I just have to kind of wait. So yeah, definitely no major concerns.
Thanks, Sarah.
Thanks, Sarah.
Yeah, no worries.
Have a great semester.
Thank you.
Let's first start with what tests with someone like that would you recommend?
Okay, so first of all, the vast majority of the athletes who come to us with those sorts of symptoms end up having negative cardiac testing. Most of the shortness of breath and chest pain that they're having is typically due to residual inflammation in the lungs. Okay.
Got it.
That being said, the heart is something that we can't ignore, and we do want to make sure that the heart is not the cause of their symptoms. So for somebody like Sarah, the 3 tests that we should start off with is an electrocardiogram to take a look at the rhythm of the heart, an echocardiogram, which again is an ultrasound of the heart. And again, at NorthShore, we do echocardiograms with strain, which give us a little bit more insight into how healthy the heart muscle is on a microscopic level. And then we also draw a blood test called a troponin. And a troponin is an enzyme that lives in the heart muscle that typically we use for patients who come to the emergency room when we're concerned with a heart attack. Because when someone has a heart attack or a acute occlusion of an artery going to the heart muscle cells die and it releases troponin into the bloodstream. Those who have myocarditis or inflammation of the heart muscle often have elevations in troponin in their bloodstream as well because of the inflammation, and some of those heart cells are actually dying. It's a different mechanism than a heart attack. We're not talking about an acute occlusion of blood flow going to the heart, but just the inflammation of the heart itself can cause a couple of these cells to die and spill troponin into the bloodstream. So an EKG, an echocardiogram, and a troponin, that's where we start, plus a very focused clinical history as well.
Okay. So the EKG is when they put the monitors on your heart and you're doing some kind of treadmill?
Not on a treadmill necessarily, but we could talk about that in a second. The EKG, a patient is just laying on a hospital bed. We're putting leads on their chest, their legs, and their arms, and it's a 10-second test. For that 10 seconds, what we're doing is we're looking at the electrical activity of the heart, and sometimes we'll see different patterns on the EKG that might suggest that even if there's normal electrical activity, there could be some structural abnormalities of the heart as well. So the EKG can give us a hint of structural abnormalities, but the EKG is not a very sensitive nor specific modality. We start with it because it's cheap, it's inexpensive, and it does give us some information, but the echocardiogram is certainly going to give us more information as to whether or not there could be any inflammation of the heart. So the combination of seeing a heart muscle where there's walls of the heart that are not squeezing normally, that's not normal in a young athlete. It's normal in somebody who's 70 who's had a heart attack in the past. But for a 16, 18, 20-year-old kid, we should see all the walls of the heart coming together homogeneously. The overall cardiac function, we would expect that to be normal in an athlete. So if we see cardiac dysfunction, in other words, global issues, that would be another concerning finding that there could be some sort of inflammatory process. And another thing that we'll often see in the setting of myocarditis is we'll see fluid around the heart. And that's often because when there's myocarditis, there can often be pericarditis as well. And the pericardium is the thin layer around the heart that insulates the heart. And when that gets inflamed, there can often be a little bit of fluid between that layer of tissue and the heart muscle itself. So those are the things that we look for on the echocardiogram when we're trying to diagnose myocarditis. We're trying to prevent a kid who has significant myocarditis from going back and participating and having an event like Chianti Johnson. When we think about myocarditis, each year there's about 75 to 100 young people who die suddenly from myocarditis. So 75, and that sounds like a lot, and it's too many. But at the same time, if you think about the number of kids between the ages of 13 and 25 who are playing, it's obviously not a very, very high number. And so far to this point, we're right now 10 months into the pandemic. When these things happen to young people, when we see sudden cardiac death, it typically makes the news. And we're not seeing a slew of patients or kids who are collapsing and having sudden cardiac death. We're hearing reports of myocarditis, there's no question about that, but as far as really, really bad outcomes from myocarditis, at least now in the first 10 months of the pandemic, we haven't been seeing so many of those.
Tell me a little bit about your background and what you're doing now with the IHSA.
I was an athlete growing up at one point in my life. I was a 3-sport athlete in high school. So
wow.
Probably should have been an orthopedic surgeon. That would have made a little bit more sense. But I just love the physiology of the heart, so that's what got me into cardiology.
So basketball?
Soccer, basketball, and baseball. I have a passion for high school and college sports, and I have a passion for the heart. So those two things come together, and that's why I've always had a passion for sports cardiology. At one point, I was the cardiology consultant for Northwestern, and I got to deal with the football players and soccer players and basketball players, so that was a lot of fun. And I've had many professional and college athletes over the years. So now we at NorthShore have decided it's time to take it to the next level and have a formal sports cardiology division. So I have taken the reins of teaming up with Ron Berger, Brian Shortle, Ellie Levy, and Mike Wallagora. So 4 other cardiologists at NorthShore that have an interest in sports cardiology. And what we're doing is we're right now in the middle of the pandemic, this is our main focus, is making sure that kids are healthy enough to go back and play. But sports cardiology goes beyond myocarditis. And we want to take people who are interested in getting healthy, with exercise and whatnot, and making sure that their hearts are healthy enough to do the right exercise. And one of the key parts of being a sports cardiologist is being able to differentiate, again, between a pathologic heart and a physiologic heart. So the 5 of us have a lot of experience over the years. Ron Berger is the cardiologist for the Chicago Bears. He's been doing that for a long time. I don't know if it's his fault that the Bears have only made the playoffs 3 times in the last 10 years or so, but we won't put any blame on him for that.
No, we'll say no.
but we all have an interest in making sure that these athletes are healthy to go and participate. As far as the IHSA is concerned, Craig Anderson, who's the executive director of the IHSA, reached out to me several months ago because one of the reasons that high school sports has really not started in Illinois to this point is, 1, because of concern of spread, but 2, because of the concern for myocarditis. And those are the 2 reasons that a lot of these sports were put on hold. And what I wanted to convey to the IHSA as well as to the state of Illinois, that from a myocarditis perspective, that's not a reason to allow these kids to participate. I'll defer to the Illinois Department of Public Health and the epidemiologists as far as the safety of participating with respect to spread of the virus. But as far as myocarditis is concerned, in these young athletes, the incidence of clinically significant myocarditis is very, very low, especially in those who get COVID and who have mild symptoms. So I've met with the Sports Medicine Advisory Committee, or the SMAC, of the IHSA, and have gone through all the data that's out there to this point. And the data is continuously evolving, but to this point, we are all on the same page that let these kids participate from a cardiac perspective. Just if they do have a history of COVID, they should be seen at the very least by their pediatrician to make sure that they're not having any of these findings that might require further workup.
And the symptoms, right?
And the symptoms. Yes.
Okay. What, for North Shore's sports cardiology clinic, what should parents do? Should they go to their primary doctor first, or go to northshore.org?
I typically would recommend talking to their pediatrician first to make sure that the pediatrician thinks that it's necessary to be evaluated by a cardiologist. And we're making sure that we get our patients in within 1 to 2 days after the consultation. And equally as important, we're making sure that we get all the testing done within 1 to 2 days, because these are athletes that do want to get back on the floor. So I take a basketball player, any sort of athlete that is interested in competing, and they had a history of COVID. We don't want them waiting weeks and weeks to see a doctor and get this cardiac evaluation. So our mission is to get all these kids in and out and cleared as quickly as possible.
And are you seeing a lot of an increase in athletes, young athletes coming?
Yeah. Certainly over the last month and a half or so, between kids coming home from college and high school kids in the area, a lot of whom who have gotten COVID. We've at North Shore now have seen well over 100 of these local athletes. So getting back to your question as far as how to get an appointment, yes, you can go to the North Shore website. I believe that the number is 847-86-HEART.
We'll put it in the description.
Okay, good.
And then, so that's how to get in touch with us, and we will make sure that these athletes are seen ASAP.
What's the benefit of having one of these specific sports cardiology programs? Yeah,
the benefit of having a sports cardiology program is sports cardiology is, again, a little bit different than cardiology in general. And it's very important to have cardiologists who have experience with being able to differentiate pathology from physiology. And again, different types of athletes, different ages, different backgrounds are going to have different looking hearts. African American hearts are different than Caucasian hearts. Caucasian hearts are different than Asian hearts. So it's important to really have somebody who has experience with understanding how the heart can look with different ages, backgrounds, and athletes.
Interesting.
Yeah. And thanks so much for being here. I loved this conversation, and it obviously has struck a nerve with a lot of parents and a lot of people out there. Not just that terrifying video. I think that was definitely an impetus for a lot more attention to this. But, like you said, COVID keeps changing. We're going to learn more about this day by day. So this is where we're at this point in time.
Yeah. And I would say, as a parent, and again, I'm a parent and I'm worried about my kids 24/7, don't go to Dr. Google. We're here for you. So just call us. We will get your kids in quickly. And again, almost all the time, it's going to turn out to be a healthy heart, and we're going to give you reassurance.
When my kids were young, it was Dr. Magazine. So now it's
What's a magazine?
Dr. Parent Magazine. Thank you so much.
All right. Thank you so much for having me.
You know, even though we are, having this rollout of our vaccine, and everyone's excited about that and getting vaccinated, we still want to remind everybody to stay safe. So wash up, back up, and mask up.
Thanks for listening.
Thanks for listening. We'll see you next time.